I wanted to welcome everybody. My name is Paul Wright. I'm the director of CITRIS, and I wanted to thank the Infineon company for sponsoring this weekly luncheon. I wanted to say hello to web viewers. We have people at other campuses that are watching this presentation, and it's our habit to put these on the web if you wanted to go back and look at some details later on. There's also another lunch, usually on a Friday, and there's some flyers at the back of the room. I believe there's another lunch this Friday, Karen. I'm right about that. But usually there's a Friday lunch of the same type that you're having now, but it focuses on energy. So take the flyer when you get to the back there. So I'll quickly introduce Dr. Stachel, Laura Stachel. As you can see from the title, the impact of her work on safe motherhood by using solar-powered light and communication is incredibly important, and she tells me that she has recently been in Nigeria 4 times to initiate this work and to make the impact that she's having. Dr. Stachel has a really distinguished career and is now working on this largely healthcare-oriented work in countries like Nigeria. She's a member of our School of Public Health, and as usual, I'd like to welcome her with a warm round of applause if you'd like to join me.
I want to make sure everyone can hear me and that you turn off your phones.
Sorry.
Can everybody hear me here? Great. Before I get started, I'd just like to get a sense of who's in the audience. How many of you are students? So it's almost everybody for those of you watching from afar. And how many of you are involved with engineering? Okay, so I'm a duck out of water. I'm an obstetrician-gynecologist. I'm also in the School of Public Health. I'm working towards getting my D.R.Ph., that's a doctorate of public health. And it's my dissertation work that brought me to Nigeria that put me in a situation that would actually lead to me coming and talking to a group of engineering people. Because of problems that I observed in the field when I did my work observing obstetric care in hospitals in Nigeria. So this is the game plan. What I'd like to do is introduce you to the issue of maternal mortality, which is a real pressing global issue. I then would like to take you on a little journey to Nigeria, show you what it's like for people who live there and people who go to hospitals, and show you the problems that led to the intervention of using solar power in hospitals. And then, because this is an engineering group, I'm going to let you in the back door a little bit and talk to you about some of the challenges and problems in trying to design solutions for the developing world. And at the end, we'll have time for questions. So first, let me start by talking a bit about maternal mortality. Maternal mortality is defined as death that occurs within 6 weeks of a pregnancy, and that could be a pregnancy that goes to full term or an early pregnancy. More than 500,000 women die each year from a pregnancy-related cause. And for each woman who dies, another 20 to 30 suffer long-term consequences and complications. So this is a very serious issue. If you were to look at the world map, you would see that the areas in which poverty are the greatest are very similar to the areas in which maternal mortality is the greatest. And if I were to redraw the map to show you the territories reflecting where most deaths are occurring, this is what the world would look like. So predominantly women are dying in Asia and in Africa. The causes of maternal mortality are listed here, and what surprised me when I went to Africa was that women were not dying of unusual diseases. In fact, they were dying of things that I saw as a doctor many, many times, things like bleeding, things like high blood pressure, that's what eclampsia is there. Infections and obstructed labor. Obstructed labor is when a baby is too big to fit through the birth canal. These are things that occur approximately 15% of the time in normal pregnancies. However, in the United States, they don't result in death because we have such an advanced system of health care to address them. Nigeria itself is the largest or most populous country in Africa. It actually has 150 million people, and it has one of the highest maternal mortality rates in the world. The area in which I'm working is in northern Nigeria, which is a predominantly Hausa region. That's the largest ethnic group. It's also the language that's spoken. There's also a strong Christian influence there. Why was I sent to Nigeria? Well, although Nigeria accounts for 2% of the world's population, it actually accounts for 11% of the world's maternal deaths. Another way of thinking of that is that of all the women dying in childbirth, 1 out of 10 come from this country alone. Another way that we look at the statistics is through the maternal mortality ratio, which is the number of deaths per 100,000 live births. In our country, that number is about 11. If you look at the slide, you'll see that it's 1,100 in Nigeria as a whole. And in the area in which I'm working, it's more like 3,000 per 100,000 live births. And an even more sobering way of looking at the same information is to say, what is an individual's chance of dying in childbirth? And for the girls depicted in this slide, they're looking at a 1 in 13 chance of dying through childbirth at some point during their reproductive life. And I've listed for you some of the factors that really seem to be at play here as causal factors, including poverty, the fact that marriage occurs quite early. The reason I chose these slides of these girls is that they're probably not very far away from marrying age, because the average age of marriage in this village was 14 and a half. There's a high illiteracy rate, very poor access to contraception, and an expectation to have large families, generally an average of 7 children or more, and they have to have a lot more pregnancies to achieve a family size of 7 because there's such a high infant mortality rate. So we're going to go now into some of the streets in a village outside of Zaria, which is the city in which I was working, and this is what you might see. You'd see men walking around, you'd see children, but you wouldn't see women. This is a Muslim area, and women are kept more or less in seclusion behind walls like those seen on the right side of the slide. But children, including girls, can roam freely during the day. Boys may be engaged in education, and in this slide, the boys are studying the Quran. There's also secular education for some, though it's not of high quality. However, girls would be much less likely to attend school and would be more likely seen walking the streets trying to sell items that their mothers may have made so that the mothers could have some discretionary income. If you were to walk inside those high walls I showed you, you might see something like this, a group of women. It's a Muslim community and polygamy is practiced, and it's not uncommon for a family to have 3 or 4 for a man, head of household, to have 3 or 4 wives and many children, and sometimes the extended families within these housing compounds could get quite large. Women engage in domestic duties such as cooking and cleaning during the day. And while we're on this slide, I want you to also take note that 97% of women in this village deliver at home. In a home like this, without running water, dirt floors, without electricity, and without light. And once you think about early marriage and that these are the conditions in which women are having their babies, it's not hard to understand why there might be such a high complication rate and why the mortality rate could be so high in a community like this. There's a model that was developed in the 1990s by 2 researchers, Thaddeus and Main, called the 3 delays, which is a framework that's used to try and describe the delays that might be encountered on the pathway to trying to get medical care if you start out with a home birth in a situation like this. So you can imagine at home it might be very difficult if you're a young girl laboring alone to even recognize when a problem's occurring. And even harder still to know when it's time to decide to go to a hospital if your family's quite impoverished. The average income in these families is $1 to $2 a day. In fact, it's only the male head of household who can make that decision. So if a man is not around the household when someone is in labor, that can be a long delay just getting someone home to make that decision. These villages don't have adequate transportation available. It may be very difficult to get a car. The cost can be high. The distance is long. And in rainy seasons, the roads themselves may be very difficult to traverse. So the second delay is the delay in transport. And finally, there's delays at the hospital, and I'm going to be talking to you a lot more about that in the next few minutes. I was invited to go to Nigeria through a collaborative project between the Bixby Center for Population Health and Sustainability and Ahmadu Bello University in northern Nigeria. They created a partnership called the Population Reproductive Health Partnership, which was a collaboration to try over 5 years to increase the capacity of Nigerian doctors to do research in reproductive health. Before I came, some of their researchers had gone into the villages and talked to family members where women had died to try and understand what happened. And they found out that a lot of the issues we've already talked about, issues with decision-making and transportation, certainly were at play. But they also found out that once people made the decision to go to the hospital, it wasn't uncommon for families to go to 3, 4, or 5 different health facilities before one would accept them for care. And that once they got to the hospital, there could be very long delays. And that's where I was brought in. I was invited to go inside the hospitals to try and understand why might a hospital turn away someone who's critically ill, because only the women who are having problems are the ones that are going to go to the hospitals. If someone has an easy birth, they'll deliver at home. So how could it be that a healthcare professional could turn away someone who's bleeding or someone who's having seizures? So I'm going to take you now inside the hospital, and you'll get a little taste of what it was I saw on my first trip, which was in March of 2008. This is the outside of a large municipal hospital. They have 160 inpatient beds. They see about 100 to 200 outpatients a day. And it's in a city of 1.5 million people, so this is not especially rural. They have electricity only a portion of each day. Although Nigeria is an oil-rich country, there's only electricity to about 40% of the population, and those that get it will only get it in a rationed fashion. And the hospital can't choose which hours they're going to get electricity. If you see in this picture, there's a white machine near the building, that's a generator. And when there's enough money for fuel, the generator is turned on and used as a backup supply of electricity. But it's not a given that there is money for fuel, and I certainly saw cases where that wasn't the case. Inside the hospital, there was no running water. This is the sink in labor and delivery. And if you look closely, you'll see there's no attachment from the faucet itself to the sink. In fact, the source of water in this picture is the bucket rather than the sink. And the metal basin on the sink was what we would use to scoop up the water and pour it over our hands over the sink. Because of the problems with electricity, they could not use autoclave machines in a regular fashion. And so the way that they sterilized instruments in labor and delivery was by trying to dunk instruments in a series of different basins of fluid containing bleach and water. There is a protocol that results in good sterilization if you have enough time, but because supplies were low, very often the equipment was really not adequately sterilized between cases. This is the pharmacy stock, and you'll imagine that for a hospital of this size, this is really not very much medicine. The government instituted free maternal child health care in 2007 and is supposed to be able to provide medications for women who are pregnant and for young children. But when there's not adequate stocks, very often it's up to families themselves to go out to try and procure the drugs that they need for their care. Here's a picture of the operating theater. I'm going to call your attention to 2 things. One is that the light that's over the operating table isn't on. Again, that's because there's no electricity, and it was very rare that I saw that light being used. The other thing you'll see is that there's blood on the floor. And that's because they also didn't have electricity to use the suction machine that would remove blood from the operating field and make it easier for surgeons to see what they're doing. And a number of times I saw that cases were canceled when they didn't have enough gauze, sterile gauze, to actually swab the field, again because they didn't have use of the suction machine. This is a picture of labor and delivery, and if any of you have ever been in an American labor and delivery, there's probably no end to the differences that you could point out. But what I'll point out to you is that the beds are metal, that there's no monitors, there's no incubators for the babies or even a place to put the babies other than the scale that's at the far end of the room, very little privacy, and really very inadequate light at night. They also didn't have a mobile communication system, and because of that I saw life-threatening delays on a regular basis. This particular girl came in with bleeding because she had a problem with the location of her placenta and needed to have an emergency C-section. The only way they could call for the doctor was to send a series of messengers to look for him, and when I finally went myself to retrieve the doctor 4 hours later, and we brought back the doctor, she had already delivered a stillborn infant. The lack of electricity also made it difficult to store blood, which needs to be kept at a constant cold temperature. And so when somebody needed to have a transfusion, as was very common in that situation where you see women who have been hemorrhaging in their home arriving in the hospital, at that point they needed to then arrange for a family member to donate blood, and they had to find someone whose blood was compatible and didn't have infections before they could get a transfusion. So that was another delay in care. And then finally, what I want to share with you is the situation with lighting. This is a kerosene lamp, and this was the main source of lighting at nighttime for labor and delivery. It's not an easy light to use because it gives very poor illumination. And I have one very brief film clip just to show you the issues with lighting. There you go. You're getting all wrapped up. So this baby is about 5 minutes old. Yeah, welcome to the world, little one. And the lights just went out. And there's no more light here in the hospital. So that was a real delivery there where a baby had just been born and literally the lights went out and we were completely in the dark at that point. And that's the case whether you're delivering a baby, whether you're doing a surgery. If you don't have control over the source of electricity and with lighting, you can imagine how difficult it can be to really ensure safe care. And indeed, this was one of the reasons that women had been turned away from hospitals, because there was not the ability to transfuse, not the ability to do C-sections in a timely fashion, no lighting, or an inability to get the doctors. So I've just shared with you all of the first impressions I had when I went to Nigeria, and I came back and tried to put together some of the things I had seen. And as you can note, there are lots of different issues in the hospital. And the project that I'm working on is only going to address one small portion of them, the electricity, the light, and the communication. But they did feel like very crucial factors in terms of factors that could affect the delays that occur in care. And so along with several other students and my husband, who is a solar educator, we created an organization called We Care, which stands for Women's Emergency Communication and Reliable Electricity. And the concept was this: we wanted to bring solar electricity to countries that have abundance of sunlight, such as Nigeria, which isn't far from the equator, so that we could provide reliable lighting, enable mobile communication, power blood banks and surgical equipment, and other diagnostic tools that require electricity. And I had the good fortune of entering the CITRIS Big Ideas competition last year. And although I wasn't one of the top winners, the exposure from that contest allowed me to get funding both from Big Ideas and from the Blum Center. And so that was the seed money that we needed to try and make this dream a reality. Some of the design principles that we had was that we wanted there to be an autonomous source of power. We wanted our systems to be durable, reliable, simple, easy to maintain, something that could be affordable and scaled to other institutions. And so this is the basics of some of our design. What we wanted to do was create standalone, primarily DC electric systems in each of the main areas of the hospital that cared for women. So that was the operating room, the maternity ward, labor and delivery, and then also the laboratory for the blood bank. And in each case, what we have is a series of solar modules which are put on the roof of the hospital, a charge controller which regulates this energy and brings it to the battery where this energy is then stored for nighttime use. We tried to create systems that would have high efficiency lighting, so we used both fluorescent lighting and LED lighting. We also wanted to have DC receptacles for charging things like walkie-talkies, which we brought to the hospital, as well as cell phones for those who had them. And we also brought in an inverter to allow the systems to be used for AC power in those situations like the suction machine in the operating room where AC power was necessary. And so we basically crafted a design for each of the rooms that we intended to bring equipment to. But before I proceeded with the installation, I felt it was very important to actually go back to Nigeria to talk with the healthcare professionals to see if this was an idea they liked too. Because after all, this was crafted up by UC Berkeley students and a few people in the community. But I wanted to know, was the lighting that we had in mind going to be adequate? Did they think walkie-talkies would be used by the staff? And so I wanted a way to show them a little taste of what the installation would be like. So my husband helped me by putting together sort of a miniature version of the equipment that we were going to use. And it had to be small enough to fit in my suitcase, so we ended up calling it the solar suitcase. And I indeed packed a lot of the equipment that you saw on that previous slide and then brought it to the hospital to show the doctors there what we had in mind. Now, I intended to just give them an example, get some feedback, and go home. But that wasn't their intention. It turned out they were very, very interested in using the equipment that I brought and said, please don't bring this home. Can you possibly leave it here so that we can be using the lights that you've brought? I had a battery charger to charge LED headlamps. I also had the walkie-talkies that you see on the right side of the screen. And so I ended up leaving the equipment there, going back to the States, and preparing for the larger installation. So, unbeknownst to me, we had started phase 1 of the project, which was the solar suitcase charging station for the LED headlamps that I had for the maternity and surgical staff, as well as for walkie-talkies. And I'm going to show you some of the results of just using these small interventions. So I'm hoping that this lighting is adequate to see just the difference in the kerosene lamp for things like taking notes at a desk versus using the LED headlamp. Here's the impact on things like nursing care. A nurse was trying to put an IV in the first slide. Something fell on the floor. She never could find it. With the headlamp, it was much easier to see her tools as well as to be able to insert an intravenous line. And even in the operating room, when the ambient light was low at dusk, you could see just the difference the LED headlamp alone had made on care. As well, the two-way radios were given to all of the people that needed to be notified when there was an emergency surgery necessary. So that's the maternity nurse, the surgical staff, as well as the surgeon himself. And so this was now used to try and reduce delays, as I mentioned. What we saw was that the lighting certainly had a huge impact. People said that it was easier to do their job. They thought it was safer, and all they asked for was more headlamps. And the walkie-talkies not only improved the speed of communication, but it changed the nature of communication. Because in the past, when they would have a messenger look for a doctor, you would only call for the doctor if you physically needed that person present. But you wouldn't call if you just had a question. So for the first time, doctors and nurses were speaking to each other to talk about patient follow-up, to ask questions, and there was less need to refer patients out of the room. We're going to need to turn these down so that we can see the rest of the slides. I don't know who might be in charge. So the next part of the project, as I mentioned, was to do the permanent installation, and because all of the staff had asked for LED headlamps, we brought those. And as the lights go down, what I'll show you is just some photographs of the staff themselves using the headlamps. On the bottom right, there's a picture of an ophthalmologist using them to do an eye exam. Are you able to see it all from where you're sitting?
We can see it, but they'll figure out the lights.
Okay. So here's an example of solar modules that are being installed on top of the hospitals, lighting being placed in the labor and delivery ward. Some of these are only going to be effective if the lights are low, but this is a picture of the maternity ward, which barely shows much more than the kerosene lamp itself, followed by illumination that was adequate for the nurse herself to put in an IV. And one of the things I wanted to do when I went back was to see whether people felt like this very high-efficiency lighting was going to do the job. Well, not only did it do the job, but the nurses said they liked the LED lights even better than the fluorescent lights, which required more energy. So when I did the installation in the operating room, I actually shifted the design and only put in LED lights. Are we going to be able to turn this down?
They're testing the fire alarms in this building today, so
Okay.
change something he's working on right now.
This is the operating room before the lights. Okay, just imagine a black screen. And this is now with 4 small LED lights on the ceiling and one that's a spotlight over the table. The entire room is only using 15 watts of energy. So that was a great surprise for us, that we could have that much lighting just using the LED lighting here, and people were thrilled that they could really finally see whenever they wanted to at night. We also brought in an inverter, as I mentioned to you, and on the right side is the suction machine, which is now being powered via the AC Inverter. And in order to try and extend the range of the walkie-talkies, because the doctors wanted to be able to leave the compound and still be in touch with the nurses, we put an antenna on top of the hospital and also brought in a repeater, 2 radios put together, which actually allowed us to extend the range to about 12 or 14 kilometers. We also brought in a solar-powered refrigerator, and this is one that uses very little energy. It uses about 40 watts of energy. And so for the first time, this hospital was able to store blood, and not only did it do such a good job of storing blood for itself, but the teaching hospital, which is a huge hospital, from time to time comes to ask for blood from this hospital now. So what was the impact? Well, what we saw was that patients were no longer being turned away from labor and delivery. When I looked at the records, I saw that in the very first month these things were instituted, the labor and delivery was able to take 30 more patients that month than they had the month before, yet they had a lower rate of maternal mortality. There was blood available for transfusions, the clinicians were very happy, and they were able to immediately assemble surgical teams. Well, I'd sort of like to end there and we could all go home, but the story doesn't quite end there because other people in Zaria heard about this intervention, and all of a sudden the hospital driver was taking me to small primary health care clinics that said, could you please bring us solar too? And I said, well, this wasn't really my intention. We were just going to work on one hospital, but once I saw the conditions in these environments, I realized that we really had to keep going. And what we found is that that solar suitcase that I had talked to you about that we had used for demonstration purposes were really perfect for small clinics that didn't need to power entire operating rooms. And so we started making more solar suitcases, and here I am bringing one to a small primary health care clinic that does about 700 deliveries a year. The midwives would virtually deliver in the dark at night. And so here they are now, both getting the light as well as getting a headlamp. So they're learning about how to use these things. I also brought it to a small hospital that had the capacity in terms of manpower to do surgeries, but never had light at night. And so we set up one of these small suitcases to provide them with overhead light for the operating table. And they no longer need to transfer women who need C-sections to the larger hospital. Okay, again, I wish I could just end right there, so it'd be a happy story. But because you're all engineers, I'm going to let you know about some of the challenges and things that happened subsequently, and maybe enlist some of your help for those of you who are interested. First of all, we really wanted to evaluate how these pilot systems were working. We also felt that we needed to optimize the prototypical systems you saw because my husband was sort of cobbling them together on the kitchen table for me. But we knew we wanted to have systems that were going to be very robust, low cost, and really stand the test of time. And we also wanted to think about how we could scale this intervention to other facilities. So in order to do an evaluation, these were some of the things we felt were important to think about. One was looking at the system components themselves and the installation. For example, the installation done in the big hospital I talked about. We also wanted to see how people were using the equipment and what the needs were for electricity in different institutions. And we also wanted to see whether knowledge transfer was occurring in a way that allowed people to use the equipment most appropriately. We also wanted to assess what the capacity was for maintaining these systems. Sorry for the typo there. So here's a little background of what was going on for installation. I told you that we did do this big installation. This was in March of this year using a company that was a local company in Nigeria. When I went back to look at the AC outlet in the operating room just 8 weeks after the installation, you can look at what was happening with the plug on the left side. It was no longer attached to the wall. The little yellow wire there is the grounding wire, which was never attached. And I also wanted to show you on the right that even on day one of the installation, when I said, please put a light that'll sort of arrive here at above the operating table, instead they left such a long cord that it literally would have been in a patient's body during surgery. And so they ended up kind of wrapping it together and kind of putting a clamp on it. And that's, literally about 60 seconds old, and that's what we sort of had to deal with. So issues with workmanship were certainly of concern. I also had brought in battery chargers, and I had meant for these to be used with rechargeable batteries. However, this was not fully understood by the staff, and people were using single-use batteries, which actually ended up injuring the battery chargers themselves. And I was lucky that my personal driver, who himself was an auto mechanic, figured out how to clean out the battery chargers so they could still be used. But it showed me the importance of really making it incredibly clear to people how to use this equipment. And this is something that Solar Energy International calls electric intoxication. This is the operating room, And instead of just being used for surgical equipment, everybody realized this was now a way to charge their cell phones, DVD players, anything that could use electricity and wood. And in talking to people who have done solar installations all over the developing world, this is a very common phenomenon. And what's important about it is that you really need to size your system in such a way that you can account for the difference in use pattern that may happen from what you intended originally. So we were very lucky. I didn't mention in some of the design principles, we purposely put huge batteries in the hospital because we wanted them to last a long time, so we didn't want a very low depth of discharge. And we also wanted people to be able to do additional charging if they wanted to, though we didn't tell that to the staff when we first did the installation. But this was just good evidence of how the equipment was going to be used in reality versus the way it was initially intended. People had different ways of putting the portable solar panels in those clinic systems that I told you about. That's the ones that use the solar suitcase. But there was a little problem with the panel they stuck up in the hospital. This again, can you see these pictures? So this again is in the hospital system where they had an installer that used a pole mount system. And what you can't see with the bright light here is that the welding joint broke where this thing had been attached to the building itself. And so that little bit was enough to just allow the whole thing to topple over. And it just was lucky that it was when I came back to visit the system 8 weeks later that we caught this. And we've now ended up taking down the pole mount system and we've done roof mounting instead. We were able to engage a local electrician to do maintenance on the system and test them. I did tell you that these were theoretically low maintenance systems, but we felt it was very important initially to do a lot of follow-up and evaluate how they were being used. So it was great to have him there as contact. And I just also want to mention how important it is to have a local champion when you do projects like this. This is Aminu, who himself is a surgical nurse, and he was the person that said, please leave the solar suitcase the first time, we can use it. I said, but you don't know how to put everything together. I had taken actually a whole course on how to wire things together, and he learned within an hour. And every day put this thing together, stuck the panels out. And it's someone like that that can really make a project work. It's really important to find, local people that really you can communicate with on a regular basis and are willing to really continue the cause. So now what we're up to is to try and work further on the solar suitcase model. We're hoping to really create something that would fit within a suitcase like this, where people could take a panel out, put them on top of their clinic, and then use the guts of the system to power lighting, to power cell phones, to power walkie-talkies and other equipment as needed. So here's some of the research and development we're doing at this time. There's a local manufacturer, Charles Liu of Everbright Solar, who's actually making new panels for us because the panels that we bought on the market were just a little bit too wide for a standard suitcase. So he's actually now creating a new shape for us so that we can truly fit them into suitcases without a problem. And then here's some other areas we're working on. We're trying to look at these LED lights. A number of the light bulbs, when I went back to visit, were actually flickering. They were not as robust as they were meant to be. These lights were marketed as lasting 100,000 hours, but 8 weeks later, I'd say about a quarter of them were really not functioning well. So we're testing different varieties of LED lights. We're also trying to make this system as user-friendly as possible, so we're creating new types of connectors so they can be plug and play. We're testing different types of batteries. This is a lithium ferrous phosphate battery that's much lighter to use than the ones that we've been using. I also had failed to mention to you that we've chosen not to go with flooded batteries to try and minimize the upkeep needed for these batteries. So instead, all the batteries we're using are sealed batteries that are gel cell or AGM. And then finally, we're looking for other equipment that are compatible with our systems. This is a small ultrasound. And we found that this ultrasound only uses 25 watts of power and only needs about 2 hours of charge. And so we're looking at ways to augment maternity care by including new diagnostic equipment that can work with the solar suitcase. So here's some lessons learned. One, it's really important to do an assessment of what the needs are of your community before you go ahead and start doing your final design. Second, it's important to do field testing. And as we saw with that pole mount, the system is really only good as its weakest link. It's also really important to have some redundancy because things can fail in the field and it's very hard to get replacements for items when you're as far away as Nigeria. So bringing extra supplies is important. Staff training is essential. I already mentioned the importance of having a local champion. We're now working on trying to develop very clear training manuals that emphasize pictures a lot so that many people can use these systems with little instruction. And again, it's important to have some plan for maintenance so that the systems can be maintained over time. So I'm coming to the end of the talk now, and then there'll be some time for questions. And what I want to talk about is what's been happening since we've put these systems in place. Well, a lot of people have gotten very interested in this project. I initially met with some of the leaders in Nigeria, both at the Ministry of Health, and on the right is actually the governor of Kaduna State, who had me address the state assembly. I then came back to the states and was asked to give a number of talks, which led to a lot of media exposure. So there have been articles, there have been podcasts, there have been radio interviews. And so that's led to some interest from people really all over the country. We had a benefit locally in Berkeley, where one of the joint medical students of our own school who plays West African music assembled a band so that she could do some fundraising locally. Then some teenagers in Boston heard one of the radio interviews and said, let's have a rock concert for We Care Solar. So in early August, this was plugged-in bands. There were 8 different teen bands who came together for an evening to raise funds for our project. And then there's a teacher in Northern California in the Elk Grove school system, Tim McDougall, who heard one of my presentations and said, you know, I think the students in my engineering class would really love to get involved in a project like this. Can we make solar suitcases? And so he made his own box. Remember I told you that those square panels didn't fit very well in suitcases? He said, let's make a box. And so now this is one of the prototypes being developed. And we ended up taking the money from the teen concert to help buy supplies for the teenagers in Elk Grove, which is near Sacramento, so that more solar suitcases could be made. And they're now starting We Care Solar clubs in the school to do fundraising. This publicity has also allowed many communities around the world to express their interest in getting solar electricity for their own clinics. So I would say I get between 2 and 4 requests a week from healthcare centers asking if we can bring things like the solar suitcase to their clinics, because electricity is such a big issue for people all over the world who live in areas that without reliable grids. And a local engineering design group, Catapult Designs, just brought one of our solar suitcases to Rwanda. And what you're seeing in this picture is that they decided to take those panels, the small panels, and actually do a mounting on top of the roof of their clinic building. And here are some nurses getting trained in how to use the system and using the headlamps that are there. So I hope that you've been able to follow this sort of rather long tour that I've given you over the last hour or so. Some of the major points that I just want to emphasize is just that emergency care is really crucial for the survival of women who are in labor, and it's really important to have a strong backup system so that when women come to hospitals, they won't be turned away. And I've tried to show how the lack of reliable electricity impairs care. I've also tried to show that there really is quite an interest and demand for solar-powered solutions, and I think the fact that I keep getting requests from all over the world is testimony to that. And I've also tried to share with you that small-scale solar solutions have both their challenges as well as opportunities. I kind of like this picture here. This is a girl that was in the hospital that I showed you. And I have one picture of her just close up, and it looks like she's behind bars and can't get out. And then you step back to this picture, and you see that sometimes the solution of getting through is just around the corner. So I kind of like this picture for that reason. Lots of people that I would like to thank. I'm not going to go through all of them. My husband is Hal Aronson. He's been the major designer on this project. I want to bring your attention to Daniel Perlman, who's the anthropologist in Nigeria who invited me there the first time. But there's lots of people within this institution who have played a big role in supporting this project and in helping me design ways to do evaluations. I also need to thank the Blum Center for their crucial support in seed funding, the Bixby Center for Population Health and Sustainability for sending me to Nigeria, as well as the other groups that are mentioned on this slide and many more that I haven't included. So thank you very much, and I'm happy to entertain questions.
excellent talk. I have two questions. Other than the statistic of 30 additional patients that they were able to see in the subsequent month post-installation, did you try to quantify some of these statistics on mortality rates decrease since the installation?
So this is all sort of happening as we speak. The last time I was there was a couple of months ago, and I did look at the statistics that they had written down. Their average maternal mortality rate per month was 5 or 6 deaths per month, and it was 1 the month after the system went in. But I basically didn't want to give that particular statistic because I felt like we need more months of data to know whether that was a secular trend or whether it was really due to some of these interventions. There is a very challenging problem in collecting statistics because people don't necessarily write down information in charts the way that you would hope that they would for doing this type of a study. And so what I'd like to do in future studies is actually create a system of documentation in clinics before the interventions are put in place so that I can trust the statistics. I was actually expecting we might see an increase in deaths rather than a decrease just because I was now focusing on writing everything down. I looked at charts where women had died and people didn't even mark down when people had died in the past. So again, the issue of documentation is really crucial, but it is an ongoing desire of ours to really try and document the changes that will come into play.
Great. And quickly, in terms of scalability, how much is the cost for one of those solar suitcases, and are you working on reducing that cost as well?
Yeah, absolutely. We're working on reducing the cost. The cost of the solar suitcase really depends on what size solar modules, what size batteries, and what other equipment go along with it. So initially the cost was around $1,000, which included solar panels as well as a walkie-talkie system. The walkie-talkies themselves are pretty expensive. They're about $200 each. So if you remove the walkie-talkies from the system, we're thinking that the components themselves will be more like $500 to $600. And that's without us even working in scale. We're now working to try and get lower cost solar modules, lower cost batteries. We've been talking with some of the manufacturers to get the prices down. On the other hand, every ounce of effort on this project has been voluntary. And so I've had no cost built in for what it costs to both build them and to ship them. And so that will, I think, increase the cost. So I'm going to tell you probably somewhere between $500 and $1,000 when you include shipping and the people putting these things together.
Hi, I was wondering about the whether there's an existing infrastructure in the places you're building where car batteries are used as storage. It's often in a lot of poor places in the world. That's the energy system, is an infrastructure of schlepping them, charging them, and then moving them back. And I was wondering whether you gave some thought to trying to plug in with existing sort of small businesses that sell power out of lead-acid batteries.
So the question was about use of car batteries. We were trying initially to design a system that wasn't going to require a lot of upkeep, so we didn't want anything that would require flooding because we'd heard of stories. Some of our team members had worked in countries where people had put incorrect fluids into batteries or forgot to do the flooding in a timely fashion, so that's why we went with sealed. But it is something that I think we will be working with as we try and figure out how do we use local materials more. At this point, we've sort of tried to say, how do we devise a system in the States that would work well there? But one of the things we're finding with scale up is we really do want to utilize local materials. I think both the solar panels we can get locally and batteries we can get locally would really help with the project. So I appreciate your thought.
Okay, well, if there are no other questions,
You're welcome.